Hello, everyone, and welcome to Ethics Grand Rounds. My name is Deborah DeBruin. I direct the Center for Bioethics here at the University of Minnesota. I'd like to begin by thanking our co-sponsors for today's event, the School of Public Health, the Medical School, the School of Nursing, and the Program in Health Disparities Research. We appreciate their partnership. A few quick housekeeping items. Today's presentation is being recorded, and the recording will soon be posted to the Center for Bioethics website. Please keep an eye out in your email for an evaluation. We would very much appreciate your input on the series. A couple of points about educational credit. First, all Ethics Grand Rounds talks qualify for interprofessional education credit for health professions students. Feel free to contact the center if you have questions about that. Biomedical engineering students, you will get ethics credit for attending today if you email the center. You'll see the email address to use for any of these issues regarding ethics credit or educational credit on the slide. It's bioethx@umn.edu. But if you lose track of that email address, don't worry. You can easily find it on the Center for Bioethics website. Just scroll to the bottom of our homepage for our contact information. Please use the Q&A feature in Zoom to ask your questions. We'll be monitoring them and we'll address questions at the end of Dr. Owen's presentation. You may submit questions at any point during the talk. No need to wait until the end to submit them. And if you have technical difficulties, feel free to use the chat feature to get help. Now, without further ado, I'd like to introduce our speaker. Dr. Mary Owen is a member of the Tlingit Nation. She graduated from the University of Minnesota Medical School and North Memorial Family Practice Residency Program before returning home to work for her tribal community in Juneau, Alaska. After 11 years of full-scope family medicine, she returned to the University of Minnesota Medical School, Duluth in 2014 as the director of the Center of American Indian and Minority Health. Her work includes developing and managing programs to increase the numbers of American Indian and Alaska Native students entering medical careers, outreaching to local and national Native leaders to ensure that the Center of American Indian and Minority Health and the University of Minnesota Medical School remain in tune with American Indian and Alaska Native healthcare and education needs, developing an American Indian and Alaska Native track for all students interested in providing healthcare to these communities, and developing research efforts to address American Indian and Alaska Native health disparities. She continues to provide clinical care at the Center of American Indian Resources in Duluth and is the current president of the Association of American Indian Physicians. I'm delighted to say that she also participates in the Minnesota COVID Ethics Collaborative, which develops ethics guidance for COVID-19 response in the state of Minnesota. We're honored that she is taking time from her busy schedule to join us today and to lead a discussion of the ethics of underfunding, changing the narrative about Native American healthcare. This is such an important topic. Thanks so much for joining us today, Dr. Owen, and at this point, I'm going to turn it over to you.
Gunashish Deb. Tudash uchat duasak, cha'ak ayachat, ushkitan nahat site, het sida dihidax ayachat, akwanda ayachat aish hat luk. Bonjour, my name is Dr. Mary Owen, and I'm from the Shark clan of the Thunderbird House of the Aquan tribe of the Tlingit Nation, and I'm also a granddaughter of the Koho. Before we get too far, I want to recognize and thank the Dakota and Anishinaabe on whose ancestral lands we have the privilege to meet and talk today. So let's get started. We're going to be running through the slides pretty fast because there's a lot of back information that I think people need to have for our discussion. Ideally, I'd be in front of you interacting, which I really appreciate doing, but we'll try to make the best of it in this format. So I'm not infrequently asked to give talks on Native health, but usually it's from librarians, students, residents, other, schools and businesses, and they always want some background on Native health and Native health disparities, which of course is really important to get out to people. But this time when I saw the bioethics folks asking me in my email box, asking me to give a talk, my mind, I got really excited. My mind went lots of different ways and thought about all the possibilities of a talk that combined the United States government, Native American health, and ethics. But, and you can imagine where my mind might have gone. But then I came back to reality and thought about what I needed to talk about for healthcare providers and to help Native patients. So this really is a talk about addressing some of the misconceptions and unknowns about where Native people get their healthcare and the persistent impact of chronic underfunding of Native health systems and services. Or put another way, it's about the impact of the US government persistently failing to live up to its end of its bargain with Native people. So this title that you see here, Ethics of Underfunding, has changed, had a couple of different changes as I prepared for the talk, and this is probably the nice title. So next slide, please. And speaking of misconceptions, I'm going to start here with a quote by JFK, or John F. Kennedy. For a subject worked and reworked so often in novels, motion pictures, and television, American Indians remain probably the least understood and most misunderstood Americans of us all. And unfortunately, I don't think much has changed since the 60s in this misunderstanding of Native people. And we're going to talk about a little bit about some of those misunderstandings today. Next slide, please. So this is a talk about ethics, and it has to include a slide of the accepted principles of medical ethics. But when I think about medical ethics and these principles, I usually have thought, I traditionally thought about individual patient encounters, but many of us also believe in how important population health is and addressing health on a much grander scale. And I think that these factors, particularly for this talk, autonomy and justice, will apply. Or that's where we'll be focused today. Next slide, please. However, being a person who believes strongly in the power of public health, I did want to see what they were up to and went and looked for their public code of ethics. And you can see here, particularly on the third one down, health justice, the third principle, health justice and equity. I found this piece here stating that there was a principle that involved remediation of structural and institutional forms of domination that arise from inequalities related to voice, power, and wealth. And I think this summarizes well what we're struggling with in our country and what we as healthcare providers need to think about as we consider how to alleviate some of the health disparities that we're seeing, not just in Native American populations, but in lots of different, but in several different underserved communities. So I wanted to include this slide for that matter. Next slide, please. Overall objectives of this talk today are to use the impact of COVID-19 on Native American populations as a illustration of the health inequities that are experienced by Native populations in general, and then to get into the truths about Native healthcare, including the origin of our healthcare and its funding, and the underfunding and the long-term effects that has on our healthcare, and how that relates to what we're seeing today with COVID-19. Next slide, please. So let's start with news that some people are aware of, but I don't know if people are aware of just how drastic the statistics are, how stark the statistics are. If you look at Navajo Nation and what they experienced, 2,304 cases per 100,000 people. We all knew about how hard New York State was hit, but look how much greater even the Navajo Nation was hit. And just imagine what it must have felt like to be down there. And as many people know, I think this, it's not too much of a stereotype to say that we in general are very community-based people, and we tend to live closer to one another. So when one person dies at a community, it has an impact that's quite profound. And this happened time and time again. So next slide, please. Now let's jump to Minnesota. These slides are brought to me, or were pointed out to me by Dr. Nick Lennertz, who gave a talk just yesterday to the medical students up in Duluth. And these are on the MDH website. But you can see here that our case incidence is not it's really not that remarkable, even age adjusted. But next slide, please. But then you start to look close, or you start to go further and see that the hospitalization rate is significantly higher. Next slide, please. And people are getting even sicker. You can see we have a higher rate of our folks who are in the ICU. Next slide, please. And even more alarming is our mortality rate from COVID. So again, these are slides from the state of Minnesota. Next slide, please. So how can this be? What about all that free healthcare? I can't tell you the number of times that I've heard this misconception that Native healthcare is free, and have had to correct it. And that's really what we're going to be talking about today. And I'll ask for your help in the end to help to spread this message. Next slide, please. But to do so, we need to step back and define the U.S. government relationship to tribal nations. As sovereign nations, Native Americans have a right to govern themselves. This was written into the U.S. Constitution. You can see here in Article 1, Section 2, and it has been upheld by several Supreme Court rulings. I've just listed 3 right there. And I believe this was from, this quote is from Johnson v. McIntosh. Indian nations are distinct political communities having territorial boundaries within which their authority is exclusive. Indian nations have always been considered as distinct, independent political communities retaining their original rights as the undisputed possessors of the soil from time immemorial. Again, this has been upheld in several different cases. These are just 3, and that quote does come from one of them, and I believe is Johnson v. McIntosh. Next slide, please. Which leads me into treaties. As sovereign nations, Native peoples and tribes negotiated treaties with the United States government. In exchange for land, nearly all treaties promise protection of reservation land and services such as medical care, education, food, and clothing. We don't have time for the purposes of this talk, but there is a long history of the U.S. not upholding its rights. In fact, very few treaties were actually upheld by the U.S. government. Next slide, please. But again, that's another talk. The reason I brought up the treaties and sovereignty is because the treaties are what's behind the doctrine of trust responsibility. From the treaties, we get the doctrine. The U.S. Supreme Court has interpreted the body of nearly 400 treaties to mean that the U.S. government has an obligation to uphold its end of the treaties by providing for the well-being of tribal people, while also critically respecting their autonomy. And you can see here that those Supreme Court rulings that have upheld this doctrine. Next slide, please. I put this slide in because we're about to talk about the Indian Health Service and healthcare for Native peoples. And I think that sometimes there's this misconception, or the stereotypes come into view about Native people, that we were solely nomadic folks running around without a civilization, without governments, without healthcare systems, without education systems. And it's quite the opposite. If you get a chance, and I have listed at the back end of this presentation a book called Indigenous Peoples History by Roxanne Dunbar Ortiz, and she will she'll teach you about our civilizations, and that we were here for 10,000, that Indigenous people have been in the Americas for 10,000 years and had systems of agriculture, of transportation, of education, healthcare systems, so much more that we just don't hear in our own history lessons. Next slide, please. This is a slide or a picture of Cahokia, which is a civilization that existed 2,000 years ago, and was around St. Louis. And it's remarkable because it is just that, a civilization, and we did not learn about it in our history books. But you can see the central area was mounds, like pyramid-like mounds surrounded by essentially suburban areas, smaller villages. Next slide, please. And this is just a quick slide about some of the traditional healthcare systems that we did have in place. You know, we had our traditional medicines, we had kinship systems. I list there Tlingit uncles in my tribe. It was important for the uncles to raise the nephews rather than the family themselves in all the traditional ways. And this helped maintain our societal structures and adhere to our health and kinship systems. Next, another important factor is our community and this long tradition of holding one another up. When you get food, and this is continued today, you always make sure that elders have enough in their houses because they can't get it for themselves. And again, I saw this when I went home and continue to see it even in the communities around me here. Storytelling, a passing on of the knowledge of medicines and different ways that we protected one another within our systems, within our communities. Next slide, please. So now we will talk about how healthcare started under the US government for Native Americans. It started in the early 1800s with some monies or some care being provided to Native people who lived around the military forts. And you can imagine that the vaccinations that were given and the healthcare that was given was in large part to protect the soldiers that were around those forts. I do want to say that the Indian Healthcare Service today supplies about 40% or care to about 40% of Native people. Next slide, please. Thank you. This is the next time, in 1832 was the next time healthcare was provided for Native people, and that came in the form of smallpox vaccinations. Obviously, this is a picture of mom with it, and then baby with smallpox, and baby got the vaccination, as you can see by the mark on their arm there. Next slide, please. And the next time healthcare monies was provided was through the Treaty of Washington, when monies were given to were given to physicians to help care for the Ottawa and Chippewa, as well as monies for medicines and vaccines. Next slide, please. Then in 1849, important date also, these are all critical dates in the Indian Health Service, or in the origin of the Indian Health Service. The Bureau of Indian Affairs transferred care of Native people. IHS still wasn't in existence. We were taken care of by the Bureau of Indian Affairs, transferred care from the Department of War to the Department of Interior. Next slide, please. And then in 1910, more monies were given out. So remember, it's very sporadic. Some monies for vaccinations and some monies for a little bit of health care, but not annual funding like we get now. So in 1910, $40,000 was given out to Native community for Native health care. Next slide, please. This is one, the Snyder Act in 1921 was one of the most important acts that for Native people and healthcare, in that it authorized regular appropriations or continuing authority for federal Indian health programs and authorization for federal health services to the tribes. Again, remember, money had come sporadically. Now there were actual programs that had to be funded on a fairly regular basis, not annually, but regular basis. Next slide, please. Regarding that last Snyder Act, and even today, it should be noted that funding for the Indian Health Service is discretionary. So it's not a guaranteed funding every year. Transfer Act marked the transfer of healthcare from the Department of Interior to under the care of the Surgeon General of the United States Public Health Service. After, you can see here, years of infant mortality, and so you can see from the red arrow that the infant mortality was about, for Native people, was 2.4 times that of all races in the United States, and 2.7 times that of white folks in the country. Next slide, please. Then in the late 60s and early 70s, a change in attitude toward Native Americans happened. So think back to 1954 and the Transfer Act, when the IHS, or the Indian Health, was transferred, or care of Native people was transferred into the Department of Health and Human Services. That was at the same time that the Menominee tribe was being terminated. So it was a pretty traumatic time for Native people. But now let's jump forward to the late 60s and early 70s. And of all people, Richard Nixon helped forward a different attitude about the health and welfare of Native people and respect of the autonomy. This then, and he said, this then must be the goal of any new national policy toward the Indian people, to strengthen the Indian sense of autonomy without threatening this sense of community. We must assure the Indian that he can assume control of his own life without being separated involuntarily from the tribal group. Termination, reallocation. And then we must make it clear that Indians can become independent of federal control without being cut off from federal concern and federal support. We have concluded that the Indians will get better programs and that public monies will be more effectively expended if the people who are most affected by these programs are responsible for operating them. So again, recognizing not just the importance of funding, but the autonomy. Next slide, please. The next critical date or time or act for Native people in healthcare was the Indian Self-Determination and Education Assistance Act. Again, this came from the change in attitudes forwarded by Richard Nixon and others. Since the passage of this landmark legislation, amendments to Title V has strengthened urban Indian health programs to expand to direct medical services, alcohol services, mental health services. But so importantly, that line there on, oh, I'm sorry, I jumped ahead on a different slide. So back on 1975, Indian Self-Determination Education Assistance Act. From the change in attitude about Native peoples came the Indian Self-Determination and Education Assistance Act. And the act was important because it allowed tribes to assume care of their services. This is really the first time that tribes could start taking control of education, healthcare, and any of the services that the government had previously supplied. And we could now start collecting for the Indian Health Service third-party revenues. We were eligible for grants. So this was a really big act for Native people in healthcare. Next slide, please. Here we go, Indian Healthcare Improvement Act. Got ahead of myself. This is the act that provided, that started the urban Indian healthcare, which I'll talk about later, is so critical to Native care today and really pertinent given the disparities that we saw in Minnesota and the number of people who now live in urban settings. Besides the healthcare for urban Indians, this was also really important because we could start more collection of Medicaid, Medicare, private insurance, and we finally saw the Indian Health Service Scholarship Program to get more of our own in caring for our people. Next slide, please. 2010 is important because it was the signed, as everybody knows, signed into law. The President Obama signed into law the Affordable Care Act, Patient Protection and Affordable Care Act, and within that act, permanently the Indian Healthcare Improvement Act was permanently authorized. Additionally, I think a lot of people don't understand that with the Affordable Care Act, Native people could sign up for it, and if they did so, they have we have no co-pays or deductibles. It increased the amount of third-party billing that we could use, and from this we have an authorization of never-ending appropriations, which people people didn't quite understand the impact of until you read back in history and realize that the Snyder Act started that, but it wasn't guaranteed. And it wasn't carried forward forever, as has happened with the Indian Healthcare Improvement Act. What's interesting to think about is what happens if we lose the Affordable Care Act. Does that take away the Indian Healthcare Improvement Act? Then we'd have to start again. Next slide, please. So this is the current Indian Health Service area by population. You can see that we live in the Bemidji area, where there are about 141,000 residents using the service area. Next slide, please. I put this slide up to show you just how ever since the Self-Determination Act and Indian Healthcare Improvement Act, how many tribes have started taking over their own facilities. And that circle there is to highlight how many, you can see on the first one on service units, 54 are now run by the Indian Health Service versus 118 run by tribal health themselves. Hospitals 24, 22, and down the way. Next slide, please. So now we're going to get to the crux of the talk today, the chronic underfunding of the Indian Health Service. But first, let's talk about what the process is. Again, Congress has recognized the importance of sovereignty for Native people and the importance of autonomy and involvement in our own healthcare. So in the preparation of the annual Indian Health Service budget, an initial team that consists of, that is called the Tribal Budget Formulation Work Group convenes, and it's made up of at least two area reps from the 12 areas that we discussed, that I showed you earlier on. And then they make up a formulation that goes to the Indian Health Service, which then goes to HHS, that then goes to OMB, which then goes to Congress, and then finally on to the president. And I circled the last piece because only once since I think 1998, I'll get to that slide later, has the budget been appropriated on time. And so tribes have had to go, like other agencies have had to go to continuing resolutions. Next slide, please. Checking the time to make sure we're on track here. Okay, this slide will show you just what that chronic underfunding, how extremely underfunded the Indian Health Service is. This is a slide that shows all the different agencies or medical healthcare systems within provided for by the US government. And you can see on the far, I always think about patients in left and right, but on the far left of the screen is the actual IHS spending per user, 3,779 versus Medicare, say, at 13,000, or how much is spent per capita on healthcare in general, which would be 9,409. So again, pointing out that significant underfunding. Next slide, please. This slide shows you our service population, and I just wanted to point out how clearly we are growing in population size, and so more people needing the services of the Indian Healthcare Service. Next slide, please. And this slide will show you the services budget and how it's the services budget is the gray line, total IHS budget is the yellow line. And then the tribal budget formulation work group recommendations is the green line. What's important here to look at how little that gray line rises, or the service budget rises, despite the fact that our population is increasing at a fairly good rate. Next slide, please. And this is what it looks like when you start to this slide demonstrates just how the funding of the IHS is not only inadequate, but it's getting further behind each year. So when you look at population increases and medical inflation, then you see the real resources lost, about 6.2 billion. And this is a slide from the National Congress of American Indians as they also come together and help with budget process. Next slide, please. So this is I just wanted to give you a quick idea of where we're going. The information on the next several slides is going to be from the 2020 April, from this year, formulation for the 2022 budget and the recommendations by the tribal budget formulation work group. Again, that group that's made up of tribal representatives from the different IHS areas. Next slide, please. And again, I'm going to highlight some areas that I think are so significant when we talk about health disparities, and particularly when we're talking about some of the things that we've already seen with Navajo Nation and the impact from COVID-19, with using COVID-19 as a marker for health disparities in general in our population. So maintenance and improvement, you can see here the backlog of deferred maintenance for the Indian Health Service throughout the country is about 650 million. They are asking, the work group recommended total funding of 478 million, which is an increase that accounts for an additional 9.6 and as far, and also inflation, accounts for inflation. Next slide, please. And just to give you an idea of the state that the Indian Health Service and our facilities are in, this slide here helps demonstrate. Most, on average, IHS hospitals are 40 years of age, almost 4 times as old as other US hospitals with an average that have an average of 10.6 years. And remember that a 40-year-old facility is about 26% more expensive to maintain than a 10-year facility. Not that you would have that in your mind from earlier, but just think about that. In more than half of the hospitals surveyed by the Office of Inspector General in 2016, administrators reported that old or inadequate physical environments challenged their ability to provide quality care and maintain compliance with the Medicare Hospital Conditions of Participation, or COPS. The facilities are also based on simplistic and outdated design, which makes it difficult for the agencies to deliver modern services. They're grossly undersized, about 52% for the user populations, which has created crowded, even unsafe conditions among staffs. And if you look at this picture I've highlighted with the arrows there, 2 hospitals in particular, think about Navajo Nation. They were served by the Gallup Indian Medical Center, which is a facility that is 53 years old, has a user population of 43,275 people. The other hospital I highlighted was Cass Lake Hospital, 77 years old. All right, and I had a chance to work at the Cass Lake Hospital not too long ago, and I say despite that, the practitioners are doing a great job of caring for patients, even in this environment. Next slide, please. I think we all know about the importance of having more modern facilities, but the absence of adequate facilities is, results in either, just as a reminder, either treatment not being sought or sought later, prompted by worsening symptoms and or referral patients to outside communities. Dr. Leonard's talked with the students about this yesterday when he came and talked to my class about impact of COVID-19 on Native people in the state of Minnesota. And you think about people, you know, we wonder about the hospitalization, and if people aren't sicker because they've been deferring their care. And then you think about all these factors in the Indian Health Service and with underfunding. For many American Indian and Alaska Native communities, these failing facilities are the only option that patients have. And if I also want you to think about, if you had your choice, would you go into a facility or go get your care at a facility that seemed antiquated and did not seem up to date with other medical facilities? Probably not, but Native people don't have those choices. And the last slide, one of the last things can you go back to the last slide, please? I want to highlight the remote area. Those remote areas are for hospitals that are over 60 minutes away from urban centers of 50,000 people. So again, people don't have the choices to go elsewhere. Next slide, please. Thank you, Kirsten, for advancing these slides. Let me see if there's anything else I wanted to tell you about this. As several tribal leaders have testified, all our patients want us to feel comfortable and safe within their environment in which care is being provided. It's difficult to do when facilities are in disrepair, overcrowded, and medical equipment has outlived its useful life. Next slide, please. Okay, the next big issue that I want to talk about, or the next area that is significantly underfunded, is sanitation. And you can see there from the second paragraph, nationwide sanitation deficiency in 2019 totals approximately 2.7 billion. And when you think about sanitation deficiency, think about what you read in the news about the Navajo Nation and the lack of sanitation facilities. In fact, all Indian Health Service areas reported high numbers of homes that require sanitation improvements, which I'll show you in a second on the next slide. Sanitation is principally funded by the Health and Human Services OCS Community Service Block Grant Rural Community Development Program, RCD, mouthful, through the U.S. Department of Health and Human Services. And without the combined resources of Indian Health Service and these agencies, access to safe drinking water and vital public health services in many tribal communities would not be met. But the tribal work group is concerned because the president's FY 2021 budget zeroed out the Rural Community Development Program. Next slide, please. And you'll see how critical that is from this slide here. Slides from the 2018 Indian Health Service Office Environmental Health and Engineering Division of Sanitation Facilities Construction Annual Report to the Congress of the United States on sanitation deficiency levels for Indian homes and communities in the fiscal year 2018. And what I want you to note here is the baseline. Every single one of these communities of our 12 areas, Indian Health Service areas, starts at level 2. In level 2, there exists an inadequate or partial water, starts at deficiencies relating to a need for capital improvement. And then look how many go on to level 3 and how significant that is in all of our communities. And at level 3, there exists an inadequate or partial water supply and sewer disposal faculty that doesn't comply with water and pollution control laws or has no solid waste facility. And then finally, look at the Navajo Nation and Alaska in that level 5. Level 5, for level 5, an Indian tribe or community lacks a safe water supply and a sewage disposal system. So no safe water supply for how many people? Imagine trying to encourage people to comply by COVID with our rules that we have around, our recommendations that we have around COVID, and not having sanitation available. People have to go to crowded areas to get more water. And when they go to crowded areas, it's more easy to spread COVID, as we've read in the news over and over and over. Next slide, please. Finally, I wanted to note the underfunding of the urban Indian health systems. And this is so important when you think about those slides that I showed you on Minnesota. Most of the folks who are impacted, Native people impacted in Minnesota, are urban. Over 70% of Native Americans are urban dwelling. I don't know that it's quite this high in Minnesota, but it's a general nationwide. And that comes from policies like termination, reallocation. Slightly more than 1% of the Indian Health Service budget is allocated to urban Indian healthcare, and there's no support from any other line item, unlike for the other health systems. Additionally, the Indian Health Service, recognizing the need across the country, has identified 17 new sites, but there's no funding for that, for those to be developed. And urban Indians, of course, urban Native people, of course, experience the same health disparities as Native people on reservations. Next slide, please. So other budget challenges that are critically important. So budget sequesters in 2013, the Indian Health Service lost a 5.1%, had a 5.1% decrease in the Indian Health Service budget. There was a reduction in service hours, staff layoffs, government shutdowns. If every single, all those 1995 to 96, 13, 14, 18, 19, you can see the number of days that the government shut down. According to Standard & Poor's, during the 2013 shutdown, according to the financial ratings agency Standard & Poor, the cost to the United States economy was $24 billion. So imagine how the IHS facility also suffers when we have to deal, our IHS services, Indian Health Service, suffer from government shutdowns. And then finally, delayed appropriations. As I said, from 1998 to 2015, the budget was enacted only once before the start of the fiscal year. And to make up for that, continuing resolutions have to be signed, which costs administrative time and energies, and ends up costing far more. So next slide, please. This is a slide that shows what the National Council of Urban Indians, Urban Indian Health, did a study to look at what the cost of the 2013 government shutdown was on urban clinics. And you can see that 12.5% of them had to close, 18 or 19% of them reduced their hours, 31% of them laid off staff, and 38% of the programs are servicing. Slide, please. So given what I've told you about that, things like old facilities, poor sanitation, or, non-modern care, reduced services because of budget shutdowns, who would have much trust in the healthcare system? I know I certainly do. Patients tend to have, it ends up in having poor follow-up for care, less adherence to treatment plans, lower health screening, you can see here. But I think most important is the bottom. Oops, something's happening. Oh, okay. I'm sorry about that. Let's try to be quiet with the papers. Thanks, guys. Most importantly, hi, Adrian. Most importantly is, I think, is the decreased status that comes from the underfunding of the Indian Health Service. Basically, the United States government is sending a message to that our healthcare doesn't matter as much, and our patients notice this, and it impacts their health. Next slide. Get rid of my chat box here. This final slide is another impact of, or one of the next impact or important impacts of chronic underfunding. This is a slide that shows the provider vacancy rates around the country. And you can see in our own area in Bemidji how great that is. It's the physician vacancy rate in the Bemidji area is 45 to 52%. Can you imagine that vacancy rate in the clinics that we use regularly? Next slide, please. So why is all of this important? What's the crux of the matter here? What's really important? And I use this slide to show you, this slide's a 10-year, this slide shows a 10-year change in the Human Development Index from the Measure of America, or and for those not familiar with this index, it was created by economists with the World Health Organization who wanted to measure countries by the health and well-being of their people, as opposed to the GDP. It's a composite of life expectancy, educational attainment, and economic well-being. And you can see here that Native Americans are the only population that are not experiencing an increase in the Human Development Index from years 2005 to 2016. Most of us accept that health is impacted by education, economic status, or poverty, but in turn, health disparities also impact education and economic status. So all the way around, that's why these issues of underfunding of the Indian Health Service are so critical for Native people. Fully funding the Indian Health Service will contribute to more than just the health of Native people. It'll increase the numbers of Native people who can achieve higher educational and economic status and live more full lives in our current system. Next slide, please. As Michael Marmot, Amartya Sen, and others have pointed out, full access to healthcare is not the only answer. Just look to England and other nations that provide their people, and you can see with healthcare, and you can see health disparities. I believe that equity in healthcare is linked hand in hand with socioeconomic equity and the subsequent capacity for individuals and communities to control their lives. But that's another lecture. In the meantime, though, fully funding of the Indian Health Service will improve health outcomes by improving clinical services and facilities, improving access to sanitation, attracting more healthcare providers, and in the end, improving trust. Most importantly, improving trust in the healthcare system by our patients and improving our patients, getting them to know how much we value their lives and how important they are. As importantly, by fully funding the Indian Health Service, the U.S. government recognizes its trust responsibility to provide for the health and welfare for Native people, while also providing us with the means to redevelop and define what our healthcare should look like. After all, it's about sovereignty and the right of autonomy and the right to autonomy of both individuals and populations. Next slide, please. And there we go. Sovereignty matters. Next slide, please. So as doctors, healthcare providers, concerned citizens, we all want to know how we can help. I've included a couple of readings here. These are really good books about the background of Native people and the true history that most of us didn't learn in our high schools and even in our colleges to a large extent. The Indigenous Peoples' History of the United States by Roxanne Dunbar Ortiz. Heartbeat of Wounded Knee by David Troyer, an Anishinaabe man from this way. Health Gap and the Status Syndrome by Michael Marmot. Won't give you the history of Native people, but I think will give you a really good insight to just how important that sovereignty, autonomy, is to healthcare for all populations. And then I would ask for you to challenge the misconceptions about Native Americans. So many people still don't understand that our healthcare is not free, that it's based on all these millions of acres of land that we gave up. And this trust doctrine that is written into our Constitution, supported by, by Supreme Court rulings and acts of Congress, as well as executive orders. And then lastly, see Native Americans. Over and over, we see slides that include Native Americans as other. And we're not seen. We're a small part of this population. We didn't start out that way, but that's where we are now. But we have critical health disparities that need to be addressed, and they can only be addressed when people see us and know that we're here. And that ends it. I went a little bit long, but let's open up to questions, please.
Thank you for that, Dr. Owen. That was a really excellent talk. So I want to, before I open it up for questions, I want to just mention one additional resource that we were reminded of as you were speaking, and that is that the current issue of the American Medical Association Journal of Ethics focuses on Indigenous health. The guest editor, Hannah Wenger, who edited this issue, is with us today and kindly reminded us. So I wanted to make sure that everyone has access to that resource as well.
That is an excellent, this month's edition is an excellent one. So miigwech for doing that edition this month.
Let me just start by asking some of the questions. I see lots of questions are coming in, which is great.
I apologize for that noise on the computer, by the way.
Pardon?
I apologize for that noise on the computer. You don't even, you don't hear those things, so.
No, of course not. Yeah, it's the challenges of presenting via Zoom.
Yeah.
We have one question about the issues that you were mentioning, the really critical issues, those social determinants kind of issues about adequate water and sanitation. And the question is, what prevents Native nations from having adequate water? Is it that the US government purposefully doesn't supply the infrastructure, or you know, do you have a sense about what are the dynamics underlying that?
I don't know that they purposely do. I think it's just a matter of priorities of funding. So they don't fund it, as I pointed out. President Trump X that piece out of his budget for, I think, 2019. So it's not again, yeah, none of this is intentional so much as, well, I don't know if it's intentional or not, but anyways, priorities. And the cost to get those services in place. You saw that sanitation number we gave to replace those aging systems and to put new systems in. It's interesting, though, what I think is interesting is that the sanitation services and infrastructure has long been part of the Indian health recognition of something that needs to be supplied for Indian health care. It's not new. So I think it's prioritization.
Thanks. So the next question relates to that framework for bioethics that you put up at the beginning and that you talked to us about a little bit. And the question is or how is that sort of framework for thinking about clinical ethics a colonialistic construct? Or what are the challenges of applying micro and macro ethical principles to Indigenous health equity, especially in relation to the Indian Health Service?
Well, the one that I looked at mostly was justice, and plenty of people, including Michael Marmot, have written about the issues around justice, and that's pretty much all this talk was about on a macro level, was the injustice of the United States not holding up to its end of the agreement. I mean, if we were going to be fair, the U.S. would just give us all that land back, right? And we'd started, you know, I mean, that's how inequitable it is. Imagine all the millions of dollars that went in, that those lands are worth. And relatively little it would take for the U.S. government to fully fund their share and live up to their share of the bargain. On an individual basis, recognizing the autonomy of patients when they come in the door, I mean, I'm not quite sure what the question's asking. It would be the same for Native patients as it would be for any others. So I may be missing it. But do you see anything else, Deb, that I'm missing?
No, I think the question is just really about ways in which maybe that framework fails to apply or imports sort of dominant culture norms into a culture where they shouldn't apply or don't apply in quite the same way. Does that make sense?
Yes, it does. And in fact, this came up, I taught our Native health lectures a couple of weeks ago or 1 week ago, and the issue of autonomy, because for me, that's definitely where so much of this revolves around. And if you look at the work of Marmot and Sen and others, they talk about how autonomy is critical to health. And if you don't have it, not just on an individual basis, but on populations, then you're not going to have good health care. So I think it does apply. I think it can easily be applied to both individual and populations. It's not a stretch for me, but I can understand where people would be concerned that it hasn't been.
I think it's interesting, just to sort of play off what you're saying there, that in bioethics, when we talk about autonomy, we often talk about it just in that individual context. And so expanding it out to having that conversation about autonomy for populations, I think is already an interesting and important move. The recognition that we need to do that, and the connection between that and, as you were saying in your talk, that notion of justice, right? Really critical.
Absolutely.
Yeah. So next question. This questioner thanks you very much for your presentation, as I'm sure does everyone. The topic of universal health care, possibly even single payer Medicare for all, popularized by a number of our political leaders, is gaining more and more attention nationwide. Even currently, California has created a task force to explore a universal healthcare financing system not limited to a single payer financing plan that would be managed by the government. Though advancing healthcare as a human right is a virtuous mission, the reality is that the current single payer movement has consistently shown a lack of respect and little acknowledgement for how a government operated plan would impact Native Americans. The question is, what do you think are the most pressing concerns that Native Americans have regarding the ever more popular single payer or universal healthcare movement?
You know, it's hard for me to imagine how that would be a problem for Native people. Because if everybody had access to healthcare, that means the federal government would include Native people in that, right? So we would take those facilities that we have where we have started to run our own health systems, and we would be able to use the money gained from our patients, caring for our patients, to help build our systems even better. So it doesn't make sense to me that you would not connect those two. Why would universal healthcare harm Native people? How I'm not seeing that at all. And I think you could easily continue to respect the autonomy of Native people. Well, it comes back to that same question. You can still give us money and we can still run our own systems. There's no conflict in my mind. Deb, do you see it elsewhere? Am I missing something again?
No, I think that, no, I don't think you are necessarily. I think the questions about the degree to which tribal nations would be included, right? You're saying that if it's truly universal healthcare, then tribal nations would be included, indigenous people would be included. And then the question is sort of the additional step that you kind of outlined in your talk about, whether there would also be autonomy in terms of how to manage those funds and how to manage those services so that it wasn't the US government simply managing healthcare for Native peoples in a way that sort of steps back that population autonomy.
I could easily see, in fact, when as I've prepared over the years for these different talks, I've realized just how vulnerable we as Native people have when you go through the different acts of termination, reallocation, and boarding schools, and just how we've seen our population numbers so affected by these different policies. And until 1970s, with this recognition of autonomy, who knew what could happen with goodwill by and even today, Congress could come along and say, well, we no longer agree with what was started in the 70s. We no longer agree with that autonomy. So certainly that could help. And certainly I think many Native people, healthcare providers, have those feelings of vulnerability. But right now, the attitude is a recognition of Native sovereignty, of Native autonomy, and the need to fund them, even if it's not held by all the people in power at this time. So I don't think that would be left by the wayside, although I can certainly understand the fear of it, having that myself.
Thanks. So the next question comes back to the issues about fresh water. And the question asks, are the communities close to fresh water as it relates to your slide on sanitation or on arid environments, specifically, for example, the Navajo tribes? The part of the question is really a question about, whether there is sort of access to fresh water sort of in the natural setting in a way. I think that's how I'm interpreting it. It's a question about sort of the history of what lands tribes were allocated and what resources they have available to them as a result of that.
So what is the question then?
It says, are the communities close to fresh water as it relates to your slide on sanitation or on an arid environment? It's a question as to whether the land the community was settled on or forced to were just bad lands, or whether the nations had been on those lands historically.
So the other place that you saw, if you remember from that slide, the other area that had significant poor sanitation was in Alaska. And those are traditional lands. We were not forced off our lands there in Alaska. And as far as the Navajo, I don't, and the Dene, we have speakers on here, including Dr. Begay, who could speak to that better than I could. I don't believe that they were transferred to those lands that are arid, but I'm not sure how that, but whether or not they are on bad lands or, you know, other populations live on lands that don't have enough water, and we make sure they have systems that are provided for them. So certainly some tribes were relocated to less popular tracts of land as with relocation, and the Cherokee and the Choctaw and many different people. But I don't know if that happened here, but nevertheless, there's still a requirement and a need for that funding for those services.
Right, you could correct for those sorts of, that lack of natural resources with an investment in, an appropriate investment in infrastructure.
As someone recently said when I was talking with them, you know, we live in not just the richest country in the world, but the richest country ever. We have some of the best technology. We can do that. We can make sure the Navajo have enough sanitation, no matter how dry their land is.
Right, right. So the next question really relates to questions about political leadership in the state of Minnesota and the effect that current leadership has. So the question is, Minnesota Lieutenant Governor Peggy Flanagan is a member of the White Earth Band of Ojibwe and the second American Indian woman ever elected to statewide executive office. What impact has her election had on relations between tribal communities and the state or federal government?
Well, I'm not a tribal leader, so I can't give you huge insight in that area, but I can tell you my perspective. When Peggy Flanagan was elected, Lieutenant Governor Flanagan was elected, within 2 weeks of her election, I had my email box filled up with people all of a sudden wanting to talk with me about different projects or this or that. And I think that there's not much more telling about the importance of us having representation in office, not just so that we're at the discussions for those conversations that are coming up about our healthcare, about all the services that that are there for us, but also about the tangles, how that goes out into the community and affects people like me who are working for Native people. Just having you there, all of a sudden people are interested in getting my input on things that they might not have had before. So it's incredibly impactful in that way. Additionally, I know because I've been on different calls with tribal health directors when they're talking with MDH, I know that the Lieutenant Governor has been meeting regularly with tribal nations since the beginning of COVID. Maybe other lieutenant governors would be doing that. I don't know. But I have to think it's because she knows and understands what our tribal nations are going through and wants to make sure that we are at the table when it comes to these critical issues that are impacting our communities. So I'm guessing that it has improved relations between the state government and tribal governments. But again, I'm not a tribal leader. And for that matter, I did want to put the qualifier in that I didn't put in at the beginning that I should have. I'm one Native person out of 5.23 million, you know, and from one tribe, and within each of our 573 federally recognized tribes, there are many different levels of assimilation, acculturation, traditions. So just keep that in mind. Speaking for myself and my experiences.
Thanks. The next question kind of picks up on those issues around COVID response and asks, what are the most important steps you would recommend now to address COVID infection, hospitalization, ICU admission, and I would add the death rate in Native populations?
You know, that's interesting. I wish Dr. Lennertz were here to talk about this too. But again, most of those numbers are from inner city population, inner city Native people, right? The ones in Minnesota. And I'm guessing that some of those numbers are, national numbers are reflecting some of the same things, although probably not with Navajo Nation and a lot of other communities. So I think it comes down to basic healthcare services and making sure people have a place to go. People have access to water, sanitation. People have access to good food so that they're not having to go out and, and expose themselves and eat not so great food and not be healthy. All those basic necessities that any population would need to be healthier. We have 25% at least poverty levels in our community. Not all Native people are poor, but when you have those high numbers, you can imagine the number of people who are struggling to survive and struggling to, prioritizing things like, basics before they can take care of their immediate health needs. So it comes back to the same with every single population: housing, jobs, education, all these critical pieces that we keep talking about, and we don't seem to be doing enough about. So.
Yeah, so what I'm hearing you say is it's access to healthcare, but it's more than that. It's also about the social determinants of health. Can you comment on the impact of trust issues on COVID response as well?
So one of the things I talk about the most is the trust issue. I've talked about our aging facilities and provider turnover. I don't know if I mentioned that one, but we have a long history of providers coming and going into our facilities for or into our health systems for some of the reasons we talked about. But in addition, there's this incentive to come in, pay off your student loans, and then leave. So really high turnover. All those factors contribute to patients not trusting the system. Additionally, how many healthcare providers really know this history about what happened to Native people or have insight into what it means to be a Native person in this society? It's not fun to talk about, but in this very structured society that we do live in, whether we want to accept it or not, this very hierarchical society, Native people are not placed very high. And that's compounded, or that's made to be clear to Native people by the underfunding of health services and the other services that we access. So to really address that trust issue, we have to fund a Native health system. We have to re-educate about the history in this country, not just with Native Americans, African Americans, all the different populations that we don't learn the truth about. We have to address this gross socio-economic disparity that we have in our country. It's no surprise that we have some of the worst health disparities given the degree of socioeconomic inequity in our country. Mm-hmm. I know that this is often where people want to go. They want the automatic answer on how you gain trust in your clinics, and you can do that in lots of different ways. You can start to do it by making Native people feel more welcome, get things on your wall, learn more about the local culture, read the books that I discussed with you, but also help me and help other doctors start to address these gross inequities in our healthcare system that I believe contribute, or gross in our socioeconomic system and our social hierarchy that I believe contribute to the lack of autonomy and the lack of justice and the lack of status for people, which in turn contributes to their poor health. Long-winded, but had to get it all in there.
No, it was good. Thank you. They're all important points, I think. The next question really relates to those issues about representation among the clinical workers. So in terms of numbers or proportion of Native healthcare workers in all hospitals or IHS hospitals. I know you just mentioned now this idea about sort of loss of workforce. I wonder, and this questioner also wonders if you can speak to the impact of that.
Sure. So I don't know how well people are aware of this or not, but only nationally, or I mean, every single year, annually, we graduate in this country about 40 Native physicians out of 20,000. That's a gross simplification of the numbers, but that's about the scale. And of course, we don't want all Native practitioners to have to go and care for Native people. That's just not fair. And additionally, we need Native people in all areas. I always quote this idea or quote the fact that we have about 3 Native gastroenterologists that I'm aware of in the entire country, right? And it's not as if Native people don't need gastroenterologists. So we're needed in all areas. We are hardly graduating any relative to everybody. That's the scope of the problem. We can, in our school at the University of Minnesota in the Duluth campus, we are trying to educate as many non-Natives as possible about these issues that I talked about, because we will never have enough Native people to fill Native physicians in our clinics. So we need everybody to have a baseline understanding to address these issues of trust. I saw on here one of the questions, if you don't mind my jumping to this.
No, go ahead.
What are the assumptions or consistent types of errors or oversights made in clinical settings by healthcare workers? From Maria. Thanks for asking the question, Maria. And I think, I often will tell people about my walking into the emergency department here in Duluth. And that just happened in the last year and a half, where I woke up in the middle of the night with I think dental pain, and I knew that I was going to have to go in. There was no way of getting around it. And I was getting ready for it. And my husband was getting ready in the other room. And at the same time, we both thought and yelled out to each other, better get dressed up. We knew that I needed to get dressed up nice so that I wouldn't get what happens to me every single time I walk into the emergency department, this phased over look, or this look of dismissal. And I've gone into the ER just in the last 3 years and had to tell someone in our local hospital that I was a physician 3 different times before they finally seemed to believe it. So if I am getting that as a Native physician, imagine what my patients and what my community members have to deal with. Sorry, not much sleep. And that status issue is a tough one. So apologies. Those are the assumptions and consistent types of, that's the crux of the error, is this gross mistreatment of Native people more than anything else. And I know that people listening to this for the most part, are the choir. And I know that you'll understand, but I need you to help me spread that message, that our patients are not being seen and they're not being treated well. And particularly in the areas with the highest impact, like the emergency departments.
So we have a question that's specifically about what physicians or clinicians can do to impact budgeting for Native health services. But I wonder if you might sort of expand that out to just talk about a little bit more about what strategies we can use to advocate for change in general.
Well, that's great. Yeah, in addition to the ones that we talked about, addressing some of those stereotypes. But additionally, you can always contact your local reps and say, I'm really in favor of supplanting or adding to that budget. I want to make sure that Indian Health Service funding is covered. I mean, most of us, I think, or a lot of us, are already involved in some form of politics. So you just extend that and reach out and say, this is important to me on the funding. Additionally, how about advocating for the funding of those urban health centers that are not, 70% of us now being urban, and 1% of the IHS budget, and those urban healthcare centers don't want to ask for more of those monies because they know it takes it from their relatives who are living in the more rural areas. It shouldn't be between us and the urban. It should be additionally to provide for those urban funding. So in addition to contacting your legislator, writing letters, and talking to people, those are the main things. Same things that we do for all these other issues that are so important to us, like the environment and education.
Thank you. It's important to sort of keep those sort of very practical things at the top of mind so that people can have an idea about how they can make things better or how they can help to advocate. Yeah.
Yeah, it's funny. I always assume that people get tired of hearing me say that one. So I try to go to more tangible things that they can do, like some of the literature. Someone asked about the American Indian History book on the follow-up email with survey. I will send out a list of the references for this talk. I don't want to send out my slides, but I'll certainly share all of the references. And those two books should be on there, as well as Michael Marmot's 2 books.
We can certainly facilitate that resource getting out.
Okay.
I also want to mention that Dr. Linda Frizzell from the School of Public Health has asked me to remind people that the School of Public Health has 6 classes in American Indian Public Health as well. So that's another important resource, and I think it's you know, we've seen a few resources now. It's good. We'll try to combine these and list them on the center website or on our social media as well, so that people have access to them. The next question really comes down to sort of an issue about kind of political advocacy for Native health. And the question is, how strong are our current Congress people from Minnesota in advocating for better funding? This sort of connects up to the point you were just making about writing to your Congress people, right? Our reps and our senators, how strong advocates are they?
Well, I believe that Senator Tina Smith is on the Senate Committee on Indian Affairs. So, and I believe that on, I can't imagine on, she's been a fairly strong advocate on some Native issues, and I believe healthcare is one of them. So, but she still could use a, you know, especially since she's on that committee, I'm sure that she would love to hear from you and your recommendations to increase funding for the Indian Health Service. As far as local, I know my local people, and I'm not quite sure where other folks are reaching out from. So.
Thanks, that's helpful. I'm going to just ask one more question because we're just about out of time. And what I'm going to do here is combine a couple of questions that got asked, and that it really relates to questions about the provider shortages or the lack of appropriate providers. And so one is really a question about sort of barriers preventing recruitment and retention. But the other is a question about is it just physicians or other clinicians as well?
Yeah, thank you for asking that question. No, we have a shortage in all areas. And in fact, the Center for American Indian Minority Health, our focus has always been on physicians, but we try to increase the numbers of all healthcare providers. And we have a summer program called Native Americans into Medicine, where we encourage Native college students who are interested in any health professions to join us, learn about research, and learn about health professions. So we are needed in all areas. I didn't have time in this presentation to show you the slides that show our shortages of nursing, pharmacy, mid-levels, all those different areas. We need them all. Regarding the barriers, if you look at another slide that I couldn't show you on here, but I'd be happy to show people another time, is the graduation rate from high school in Minnesota for Native students is about 50%. Sometimes it'll go up to 50 to 60. In Duluth, Minnesota, where I'm at, it's 52%. So if you take that number of high school students graduating, and maybe a quarter of them go on to college, and of those, maybe a quarter up to 40%, if you're being generous, graduate from college, and then how many of those are interested in getting the sciences that we need, or how many of them have had the good support through school to be at the level where you could compete in those science classes and get the numbers that you need to get into medical school. We're down to so little number. That's the key barrier. We just, our feeding, ground is dry. We need more of those students. So I always tell people we need a pipeline that starts prenatally to practice and goes all the way to practice. We don't need to start just in college. And I know that that's exciting to people because we're going to get faster turnaround. But if we had started this 25 years ago when I started medical school, we'd have that many more ready to apply to medical school now. Yeah. Right. Thanks for the excellent question.
And thank you. I mean, we're out of time at this point, and I want to make sure I honor people's time and your time. So let me just once again express my really deep gratitude to you for presenting to us today. This is such an important kind of set of issues for us to be thinking about, and when we think about our commitment to health equity. And so I am really grateful, Dr. Owen. I also want to invite everyone to join us for our Ethics Grand Rounds presentation next month. I'll be presenting with Professor Susan Wolf on ethical issues in COVID-19 response in the state, with a sort of special focus on concerns about equity across populations. So hope to see you then, and thanks everyone for joining us today.
Is it just us, or